Hello, and thank you for your interest in Pinpoint DNM. My name is Tanya, and I'm very excited to share it with you. This video is an introduction to the dermoneuromodulating approach by Diane Jacobs and introduces some of its core concepts and the general technique from the full course. By the end of this video, you'll be able to put 6 techniques to use right away and see how the concepts are just as valuable as the hands-on applications, because that is what drives the techniques to be so effective. Okay, so here's what we'll pack into the next 45 minutes or so to get to the technique. The full course itself is about 30% theory and 70% hands-on practice. In it, we go into a lot more depth and detail on how to treat specific cutaneous nerves for various pain presentations and expand further on the principles featured in this video and so much more. But for now, enjoy this introduction to the paradigm-shifting approach of DNM and get all you can out of it. We'll be moving through a lot in a short amount of time to get you all the basics that will bring the technique to life. So take notes and remember you can always pause and come back if you need a break. And please know it's not a good idea to jump ahead to the end, because then the nuance of the technique won't make any sense and you'll basically just end up squeezing people, which can be nice, but that's not the point of DNM, okay? Great. And here is the official DNM manual. For more information, please visit dermoneuromodulation.com. It's available in a few languages too. So before we jump in, let's see where we're at. Do you or do you not agree that our central nervous system is the main system in charge of governing all our body's physiological and motor responses, and that it is what keeps our bodies alive and aware in the world? If you do agree, then DNM is right up your alley and this video is for you. And if not, well, I'm curious to hear why not. So at the end, send me a message through email or Facebook if you like and let me know. Either way, you'll still see how DNM can be an advantageous addition to any practice. Okay, now the first step in exploring the full potential of DNM is all about grasping the specific evidence foundational concepts of it and welcoming new perspectives into your practice. I realize some of this might look a little different than what you're used to seeing in most manual therapy modality classes, but these concepts are extremely valuable to note if you want to stay ahead of the curve. And once you get a handle on the basics, you'll be amazed at how liberating this approach is and how it embraces and complements everything you already do. Again, here's a look at the overview of everything that will jumpstart you into the technique. Right? First, we'll go over what is DNM, neurodynamics, the skin-brain connection and touch physiology, pain neuroscience education, therapeutic alliance and movement, the gait control theory, and then we'll get into the technique. Okay, so what is DNM anyway? And don't worry, we'll get into why it's called dermoneuromodulating in just a moment. But in a nutshell, DNM is a pragmatic neuroscience-based approach to manual therapy that informs both the therapist and patient on how to hack the nervous system and persuade it to reboot itself. And its framework can help treat a large number and variety of pain presentations and conditions sensibly and safely. Now, in order to practice DNM as effectively as possible and encourage this rebooting, it makes a big difference to have an accurate understanding of how touch is perceived and processed by both the peripheral and central nervous system, especially in the nervous system of anyone experiencing any degree of pain. Well, what is needed to reboot? Well, of course, first a practitioner needs to understand the science-based code of neurophysiology and pain mechanisms in order to help someone hack and reboot their nervous system. This rebooting is similar to how a top-level computer programmer not only knows how to write and rewrite software code, but they also have an understanding on how the machine itself and the hardware software runs those codes. Great programmers understand how the code they type gets processed through the keyboard keys and through microchips, and how all that jargon will appear to the end user. This is how they problem solve and troubleshoot and make updates to any program and essentially reboot the system. It's because they understand the power and language of computer code. And just like that, DNM is the understanding of the basic science-based code for helping someone hack and reboot their nervous system. Okay, so we know technically the human brain and nervous system don't at all function like computers, as brains are infinitely more varied, complex, adaptable, and changeable. But the learning and application principles of DNM are similar. Here's another way to think of it, and keep this in mind throughout the rest of this video. So if we want to think of the brain like a computer's central processing unit, then we can think of the skin as being like the keyboard. And that's why you'll see DNM uniquely emphasizes skin as the primary interface when techniques are applied. Now, as soon as you realize that as soon as you're touching someone on their skin, you're touching their brain directly, it will change your entire worldview about manual therapy. And that's exactly what the concepts outlined in DNM did for me in my practice, and why I'm so happy to share this approach with you today. Now, let's clear up what DNM is and isn't, and how, whether you realize it or not, everything you already practice can operate under these same unified neurophysiological principles, making DNM a valuable and sensible approach that supports any practice. The magic word here is approach, which means DNM is not a modality. And I know what you're probably thinking. And that's a good thing, because this means that you can apply some or all of the concepts to any of your favorite modalities. It's kind of like this. Whether you read or play music or not, all melodic sounds are subject to the same rules, which is what makes the difference between music and just noise. Fundamental music theory exists and applies to all genres of music. Consider how an understanding of music theory, either intuitively or formally, helps a musician get the most out of their instruments and even play them better, and be able to pick up new ones with greater ease. Understanding the concepts in a theory and then deciding how you will engage them in practice, this is your approach. DNM is the theoretical approach, and a modality can be considered the instrument that is played or used in your practical approach. And there are many modalities, just as there are instruments. However, the same music theory applies to all musical instruments, just as it does to modalities. Make sense? That's why the concepts in DNM are so useful. So there is a big difference between a modality and approach. I hope you can see that. Again, modalities are like your instrument. Trigger points, myofascial release, acupressure, etc. are all different modalities. And I hope you might notice how they all claim to target and affect different structures, muscles, joints, or fascia, but as you can see, they all clearly involve contact with the skin. Now, to be fair, I think we can agree that some theories are more plausible than others. The truth is, we now have access to so much more accurate information about neurophysiology than was available to us only 20 years ago. So don't you think it could be a good idea to leverage that information for best results? So here's what DNM is. DNM is short for dermoneuromodulation. Dermo references the skin, because when you really think about it, that's all we're ever actually physically touching, right? So why has our richest sensory organ been so overlooked until now? Neuro is a nod to the system which oversees all systems, our nervous system, and highlights the symbiotic connection between our brain and skin, and how important, obvious, and strong that connection is in manual therapy. And modulation is about the changes possible when touch and movement are employed with an accurate understanding of how the skin and brain and all our moving parts work together. So very simply, dermoneuromodulation is any approach that recognizes that interacting with the skin in a particularly well-researched manner can help alleviate a wide variety of pain presentations and literally help give someone a better sense of themselves. So to summarize so far, DNM is an approach that follows logical physiology and is an updated conceptual framework founded on the most evidenced and current understanding of how the nervous system responds to touch and how other underutilized inputs can affect or alter the outcomes of manual therapy as well. We'll address those other inputs and how to hack them in just a little bit. But simply, DNM is just an underlying framework for how all manual therapy works. That's why it's an approach that can set itself apart from the modality mindset. Now, I know that all that sounds like a modality, especially with a name like dermoneuromodulation, but it had to be called something. And as the name suggests, DNM is any modality that considers the entire nervous system, from skin cell to sense of self in each therapeutic interaction. Now, if you don't already know, DNM was developed and pioneered by Diane Jacobs, notably after she attended a class with Dr. David Butler about the nerves and pain mechanisms. After digging into neurodynamics and pain science, Diane became very interested in the highly ignored cutaneous nerves that reach from the spinal cord all the way out to the skin organ, and recognized that these same neurodynamic concepts apply to all nerves. But why hadn't anyone noticed these? In 2007, she performed a cadaver dissection at the University of British Columbia, mapping the cutaneous nerves, and has been teaching DNM around the world ever since. Her textbook was published in 2016, and not only did it build a practical, evidence-based case for manual therapy, but it has also created a community of professionals from across many disciplines. Now you can find DNM practice around the world and taught by those of us who had had the great opportunity to learn directly from Diane, that there is indeed a more purposeful and kind way to work with people in pain. As a matter of fact, kindness is a noted characteristic of the quality of touch needed for DNM, along with the other underutilized inputs we talked about earlier. Keep all of these in mind for when we get to the technique at the end. Okay, now let's talk about how neurodynamics fits into the DNM framework. Here's a quick overview to start. So as you might already know, neurodynamics refers to the communication between different parts of the nervous system and the nervous system's relationship to the musculoskeletal system. It's also known by some as nerve mobilization. DNM is also a neurodynamic application, however, with a unique focus on the cutaneous nerves. Neurodynamics recognizes nerves move independently from other tissues, and treatments consist primarily of mobilizations of the main long nerves of the system, such as the median nerve and sciatic nerves. DNM is also a neurodynamic application, except its techniques primarily target mobilization of the cutaneous nerves in the skin. But let's travel back for a brief moment to see how neurodynamics brought us to DNM. So neurodynamics has been in research and development for over 30 years. It was first introduced in 1978 by a Swedish neurosurgeon named Alf Breek, who called it adverse mechanical tension of the nervous system. Adverse mechanical tension, or AMT, is now more commonly referred to as adverse neural tension in neurodynamics, and we'll get to that in just a moment. It gained traction when Dr. David Butler and Dr. Lewis Gifford studied Brieg's work and subsequently presented the paper, The Concept of Adverse Mechanical Tension in the Nervous System, in the British journal Physiotherapy in 1989. They are also two of the most notable influencers in bringing current pain research and education into manual therapy, giving it science-based and truly holistic underpinnings. Following that, Michael Shacklock coined the term neurodynamics in 1995 after working with David Butler and Helen Slater in Australia and becoming familiar with the neural tension approach. He published neurodynamics in the British journal Physiotherapy in 2005, then released the book Clinical Neurodynamics. Then sometime in the late 90s, Diane Jacobs took a class from Butler about the nerves, nervous system sensitivity, and pain mechanisms, and realized that's what she'd been working with all along. And that these concepts could also apply to most manual therapies. She began researching everything about nerves in great depth and realized there had been an entire body of innervations that had been overlooked in manual therapy and were easily accessible through the skin, these cutaneous nerves. So DNM focuses on mobilizing specific cutaneous nerves. So basically, DNM uses a neurodynamic approach that specifically focuses on mobilizing cutaneous nerves to help relieve various pain presentations, which may have been missed by other neurodynamic approaches. These both work very well together in addressing the nervous system as a whole and in treating similar types of conditions. So some of the pain presentations that DNM as well as other neurodynamic approaches can help with are nerve entrapment or compressions, tunnel syndromes, neural irritations, muscular bracing or spasm, musculoskeletal pain, limited range of motion, nonspecific pain, and discomfort, and several other presentations of musculoskeletal dysfunction, which are often actually the result of adverse neural tension. And here's how all these neurodynamic approaches for pain relief work, including DNM. So in order to work with DNM or any neurodynamic techniques as usefully and efficiently as possible, it's important to have a general understanding of the neurophysiology and mechanics of neurons in the context of pain syndromes, which also leads to having an understanding of foundational pain neuroscience. We'll introduce that and the role of the cutaneous nerve specifically in the next few sections, but now here's what's generally happening during nerve mobilizations. But first, there are 3 things to check off about the nervous system. Number 1, the nervous system is very busy. The sole purpose of the nervous system in any living thing is to sustain its life. Though it makes up only 2% of the total body mass of human beings, that 2% does the entire job of keeping us functioning and regulated all day, every day, whether we're asleep or awake, until we croak. This requires lots of constant monitoring. That's why there are 72 kilometers or 45 miles of neurons squeezed into our bodies, extending into and out from every single tissue to monitor and adapt accordingly and ensure survival in our day-to-day lives. Number 2, the nervous system is very greedy. All of this monitoring requires lots of energy in the form of oxygen and glucose delivered through the blood. So even though the nervous system makes up only 2% of our body mass, it consumes 20% of the entire body's oxygen supply. Many parts of our circulatory system run within and alongside our neurons to nourish and supply them with the energy to do their job. And in turn, those same neurons regulate the autonomic vasodilation or constriction of those blood vessels. They are interdependent on each other to keep everything running smoothly. And finally, the nervous system can get very, very cranky. Now, if our ravenous nervous system doesn't get the oxygen and glucose supply it needs or enough movement to maintain itself, it can become very cranky. Kind of how you might if you forget to eat lunch or don't ever take a break to go outside and get some fresh air. Sometimes if the vessels are compressed in a certain way for too long, they can't deliver the optimal amount of oxygen to the nerve. And sometimes when that happens, pain presentations can arise. Just like if you've ever sat on your foot for too long, enough to cut off some of the circulation, you'll eventually feel your body scream at you to get off of it. This comes in the form of unpleasant prickles, or what we call as your foot falling asleep. And we can agree that unpleasant sensation works very well at getting our attention. And as soon as you notice, you take action, change position, and your foot goes back to feeling like itself again. But if that neural tension has been happening on a micro scale over a longer period of time, the nerves might need a little external help in finding free movement again. And that's when manual therapy comes in. Adverse neural tension can be described as abnormal physiological and mechanical responses produced from the nervous system structures when their normal range of movement and stretch capabilities are tested. This can present as burning, numbness, paresthesia, pain, limited mobility, weakness. So if adverse neural tension is a well-known underlying factor in specific pain presentations, and we know it can occur in any nerve branches, why are the cutaneous nerve branches still so ignored? Especially in cases when nothing else seems to be helping, and DNM has shown it can help in so many of those cases. So DNM elicits positive outcomes by attending to different entwined aspects of the nervous system. And of course, one of those aspects is biomechanical, to help with nerve issues such as compression injuries, tension, and entrapment. How does that work? I'll show you in just a second so you can keep these concepts in mind when you learn the techniques at the end. But see these individual axons? They're all bundled together in these fascicles until they branch out to reach their innervation, quite often all the way out to the skin. A fun fact is that 3/4 of our somatosensory cortex, that's about 75%, is dedicated to processing cutaneous innervations from the skin, while only the remaining 25% is for processing proprioceptive inputs from muscles and other connective tissue. So each fascicle is covered in a protective layer called the perineurium. And all of these fascicles are bundled inside the epineurium, the outer covering of our peripheral nerves. These tissues surrounding a nerve can have a profound influence on the ability of a nerve to move and adapt to changes in bodily positions. These outer connective tissue layers provide protection for the peripheral nerves. However, blood vessels in the nerves are still prone to compressive forces from either the inside of the body, as with an antalgic posture, tension, or stress, or from external factors such as injury. And just like any other tissue in our bodies, the nerves require a blood supply. And in turn, that blood flow is also regulated by the nervous system in an interdependent alliance. So if circulation and or signal is reduced in either afferent or efferent transmission, this can create or exacerbate symptoms of adverse neural tension and other pain presentations. DNM addresses the same neurodynamic disruptions in the cutaneous nerves via the skin. So there are many wonderful neurodynamic applications to help test and restore healthy circulation and signaling to the larger nerve trunks, like the sciatic nerve. But DNM has expanded to address the cutaneous nerves in the skin, where the solutions to many other pain presentations have been hiding in plain sight. Next, we're on to my favorite part, the skin-brain connection. You're about to see how valuable and crucial it is to consider the huge role the skin plays in manual therapy applications and how to work with it in new ways, in addition to taking even fuller advantage of the modalities you already know. This is because the skin is literally the outermost layer of the brain. Keep in mind, the understanding of this connection supports how manual therapy can serve as a powerful mediator in pain modulation. And here's how that connection develops. It starts in the womb and continues to inform us throughout life. Basically, our skin and brains are made up of the same embryonic germ tissue, and this establishes their connection in utero. This image shows an embryo at about 3 weeks into development when the first cells begin to differentiate into what will eventually become a beautifully intricate system of organs and tissues with highly specialized functions. At 3 weeks, the process of organ development, called organogenesis, begins and pretty much continues up until birth. Every organ in our entire being is born from only 3 types of cells in the embryonic germ layers. Endoderm is the innermost layer, and these cells differentiate into our digestive system, liver, pancreas, and most of the lungs. The mesoderm is the middle layer, and these cells are at the heart of muscles, bones, connective tissue, our circulatory and cardiac tissues, endocrine glands, and the urinary and reproductive systems. Basically, the tissues the majority of manual therapy modalities aim to target. And finally, the outermost layer is the ectoderm, which becomes our skin and then our nervous system and brain. This happens as the ectoderm folds inward on itself during fetal development. Ectoderm is what we're most interested in DNM and what's generally been ignored in manual therapy. Let's look at how interconnected the skin and brain really are, more so than any other tissues. So during the embryonic period, part of the ectoderm thickens to form the neural plate, which forms a tube that will become the central nervous system at our core. The central nervous system first takes shape when the neural plate begins to fold in on itself until its borders meet to form the neural crest. This neural crest is what develops into our peripheral nervous system, while the center of the neural plate folds in to become the neural tube. And all the while, the epidermis continues to expand on the outside, maintaining its ectodermal cellular connection to the neural crest and the neural tube through developing neurons that elongate and remain connected as the fetus grows from the outside in. That's right, our nervous systems develop from the outside in, beginning with the epidermis and central nervous system. Then what innervates out from the central nervous system is everything else that lies beneath the epidermis and sprouts from the layers of mesoderm, the middle layer, and endoderm, the innermost germ layer. This is why our skin is our first protective layer and our richest sensory organ, and also the one that responds most profoundly to touch in the form of any manual therapy modality. It's been informing our development all along and will continue to inform our brains of the world around us throughout our lives. And this is why 75% of our somatosensory cortex is devoted to the innervation of the epidermis. As practitioners, we don't have direct contact with any other tissue besides skin, where we're only 3 neurons away from the brain of the person whose skin we're interacting with. The first order of sensory neurons begins with a cutaneous nerve, the longest nerves in our body, which send a tactile stimulus, let's say it's a compression manipulation, to the dorsal column nuclei of the medulla. We'll save what happens with unpleasant stimuli for when we get to the gate control theory near the end of this video, but for now, just appreciate how the cutaneous nerves are so long that a single neuron can run all the way up to the brainstem. So from the dorsal column nuclei, a second order neuron decussates or crosses the midline where the stimulus gets sent to the thalamus. where it then gets relayed to its mapped location in the somatosensory cortex to be interpreted, so an efferent response deemed appropriate by the nervous system can be initiated back out to a muscle or other effector. As soon as we become aware of how close the skin is to the somatosensory cortex of the brain, we can learn to address it and work more efficiently overall. The skin is an extremely powerful interface that has been right under our hands this entire time. And remember again, 75% of the somatosensory cortex right here is dedicated to the cutaneous innervations in the skin. Now let's introduce one of its most useful sensory mechanisms. So there are specialized sensory receptors in the skin, each responsible for detecting different tactile stimuli and other stimuli like temperature, vibration, light, itch, or noxious stimuli, which is any stimuli perceived as a threat by the nervous system. The receptors that DNM applications primarily interact with are the Ruffini corpuscles. And when you understand their role and how to leverage them using a very specific quality of touch, we'll be able to realize the full therapeutic potential of manual therapy. Keep all this in mind because you'll need it when we get to the technique in just a little bit. In your notes from the first 10 minutes of this video, you may have written down the characteristic qualities of touch found in DNM application. The reason for this is that the specific stimulation of Ruffini's corpuscles requires slow, sustained, warm handhold with skin stretch because the Ruffini also respond to warmth. And the contact should be light enough to avoid triggering the patient's discomfort. This exact quality of touch is believed to cause the relaxation response felt deep to the contractile tissues beneath them, which is exactly what we want when addressing musculoskeletal complaints. We want the greatest effect in the shortest amount of time. And the best way to achieve this is by understanding the underlying physiology and working with how the body naturally works. This is a huge part of the DNM approach. So if you didn't already note the guidelines of slow, light, and kind, now is a good time to do so. Next, you'll see why kind isn't just a nice thing we say, but that the quality engages very real neurophysiological mechanisms that are crucial in the treatment of pain. Okay, so now we have a good foundation on the important role of the skin in manual therapy, particularly in DNM, and how neurodynamic applications to the cutaneous nerves can address biomechanical issues. But what about engaging the actual brain? We know it's directly connected to the skin at the other end. So wouldn't it be wise to include the most critical organ of the body in the treatment process also? The DNM approach also recognizes that because the brain is in fact part and parcel of the skin, it's also important to cognitively engage it through pain neuroscience education. Here's why and how it works in DNM. Okay, so pain neuroscience education is a treatment approach for various and sometimes challenging pain presentations that involves sharing evidence-based education about the underlying mechanisms of pain with the patient, in everyday language, of course. This actively includes them in their own treatment process and lays the foundation for lasting results. By definition, it is an educational strategy used by clinicians that focuses on teaching people in pain more about the neurobiological and neurophysiological processes involved in their pain experience, especially chronic pain. Pain is extensively discussed in impeccable detail in the 2017 paper, A Clinical Perspective on Pain Neuroscience Education, Approach to Manual Therapy. But for now, we'll just touch on the basics of why and how it's incorporated into the DNM approach. This 2019 systematic review and meta-analysis on the efficacy of pain neuroscience education for chronic pain shows that pain neuroscience education facilitates a patient's ability to cope with their condition, produces clinically significant decreases in kinesiophobia, or fear associated with movement in general, or a particular movement, which is usually one that has been painful in the past due to past injury or other dysfunction, and produces clinically significant decreases in catastrophizing. These are the intense negative feelings and beliefs a patient may have about pain that can notably exacerbate the perception of it. PNE can help clear out any misunderstanding or misinformation at the core of those negative beliefs, which in turn can often significantly help in reducing pain frequency or intensity. And since these are outcomes we definitely want to facilitate, it makes sense to incorporate PNE into manual therapy treatment settings where it's a seamless fit. Which brings us to the question of what exactly is pain anyway? In July of 2020, the International Association for the Study of Pain, or the IASP, updated the definition of pain to be an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Note the keywords: an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. With that definition, the IASP has added 6 additional crucial points that further align with the updated evidence-based knowledge we now have about pain. But we're just going to focus on these first 3 really quickly, and the 4th, of course, goes without saying, which reads, a person's report of an experience as pain should be respected always. So the first, pain is always a personal experience that's influenced to varying degrees by biological, psychological, and social factors. In 1977, an internist and psychiatrist by the name of George Engel introduced the biopsychosocial model of healthcare, which put forth the concepts that our biological and physiological states of health are strongly influenced by psychological and sociological or cultural factors, which is why understanding a patient's beliefs and relationship with their own pain is number 1 on this list, so we can help treat them more holistically. Second, 2, pain and nociception are entirely different phenomenon. Nociception is defined as the neural process of encoding and processing noxious or threatening stimuli. Through this process, the body initiates a physiological response to a threat represented by the nail in this image, and then engages its defenses. In this example, if it were me, I would remove the nail or a splinter while white blood cells are deployed by my immune system to destroy any bacteria, and vasoconstrictive responses reflexively work to stop the bleeding. Now, if you've ever looked down and noticed a scratch and wondered how to get that without ever even having felt whatever scratch you as it was scratching you, you understand how nociception can exist without pain. Now, anyone who's ever experienced grief knows pain is highly felt and complex. It's an experience that can exist without tissue damage. And ultimately, patients come to us for the treatment of their pain, not the treatment of nociception. Although pain and nociception often accompany each other, they must still be recognized and treated as entirely distinct presentations that can and often do exist independently from each other if we ever hope to see better outcomes in the treatment of complex chronic pain presentations, which have reached epidemic proportions in our modern society. And third, throughout their life experiences, individuals learn the concept of pain. Now, there is a lot to unpack here, but to keep it as to the point as possible for this video, this is exactly why it's important to introduce PNE into our work. We aren't only working with someone's epidermis, muscles, or other structures, but we are engaging with every experience and belief they've had with pain throughout their lives, whether it's conscious or not. And as uncovered in this 2015 systematic review, which analyzed over 57 studies on how growing up with one or more parents who've experienced chronic pain can impact the lives of offspring for years to come. So this meta-analysis reviewed over 57 eligible studies, 31 of which were population-based, reporting on a total of over 4.5 million offspring. And the results clearly show that chronic pain tends to aggregate in families. And I think we can all agree that these are the contexts where most of our general beliefs and behaviors about life develop. So is it any surprise that the population studies also reveal that offspring of parents with chronic pain were more likely to have pain complaints themselves and internalize and externalize problems regarding pain compared to other offspring? This is just one example of why pain neuroscience education is woven into the DNM approach, because we can't help shift long-term pain perception unless we also address misconceptions a patient may have learned about pain, such as, if it hurts when I move, that must definitely mean something is damaged and getting worse. Or no pain, no gain. So manual therapy must be painful and I need to tolerate this. Or I'll never be able to run or dance again if there's pain. What's more is pain neuroscience education can become a lifelong research for the patient throughout their lives and one they can share with others. It also helps build self-efficacy and resilience and can show the patient it's okay to trust their bodies and that hurt does not always mean harm. And this is all achieved through nurturing a therapeutic alliance with the patient, which brings us to our next part. Okay, so hopefully by now you have a much better idea of why there are other equally important pieces to the DNM approach, besides just hands-on techniques, which we'll be getting to in just a moment, promise. So DNM in no small way addresses the entire nervous system, from skin, cell to sense of self, in each therapeutic interaction. Those are the words of Diane Jacobs, and here's the key word, interaction. In 2011, the Journal of Manual and Manipulative Therapy published a letter from Diane Jacobs and Dr. Jason Silvernail, in which they call out the importance of shifting the operative mindsets of manual therapists to that of a more evidence-based and interactive alliance with the patient. So what exactly does this mean? Let's note the major difference. The term operator implies that the patient is a passive recipient of the manual act. As an operator, the practitioner uses modalities and makes recommendations with little, if any, input or guidance from the patient to address issues usually labeled as structural or tissue-based in nature. Kind of like when a carpenter gets a hammer and uses the hammer on piece of wood or something, that is kind of how an operator operates. Whereas the interactor model recognizes the context of treatment, including the technique, the provider, the participant, the environment, and the interaction between these factors may contribute to patient outcome. The interactor understands there are more complex factors besides structure and tissue at play when it comes to working with pain. The interactor asks questions, offers science-based reasoning, and elicits feedback and guidance from the patient, and engages the patient in their own process of finding relief through movement and incorporating pain neuroscience education. Overall, the interactor model is aligned with the more holistic and science-based biopsychosocial model of care we talked about earlier, which is why DNM is as much about understanding concepts and working with cognition as it is about the hands-on techniques. Without a mutual trust and alliance between the therapist and patient, our techniques are not realizing their full potential. So yes, the concepts and applications of DNM do focus on the peripheral and cutaneous nerves, but they do so while treating the entire human as if their nervous system really mattered. So another way of looking at this is that DNM is about fostering the therapeutic alliance through our technique for the purpose of supporting patient self-efficacy in the treatment of pain. So another important ingredient in the DNM approach is providing the patient with easy-to-do movement homework, and all this ties back to the neurodynamic foundations of DNM. Research evidence shows passive manual therapy is nowhere near as effective without the inclusion of active engagement and movement practice on behalf of the patient in the treatment of chronic pain. Now here we are at the last section before we get to the technique. So congratulate yourselves for getting this far, because now this is all going to make a lot more sense. So besides relieving biomechanical compression on the cutaneous nerves, the non-invasive handholds of DNM also help relieve pain via this pathway. It's the same pathway that makes our knee feel better when we instinctively rub it after hitting it on the corner of a table. Keep this detail in mind too as you practice. In short, this is at the heart at the gate control theory of pain. Before we continue, keep in mind that this is still technically a theory. However, it is one of the best working models we have for how touch might help alleviate pain. Okay, so let's say this nail represents where pain is felt or perceived, even in the event of no biomechanical disruption or injury. Or if there was no sudden bump against the table, just hurts. Now, a quick review. Remember, the first order of sensory neurons carry a stimulus to the dorsal column nuclei of the medulla, where the stimulus then gets relayed to the thalamus and then to its somatosensory location in the cortex. But what if the stimulus is unpleasant or perceived as threatening? Threatening or danger stimuli is known as nociceptive input, which, remember, is not the same as pain. Here, the first order neurons carry the nociceptive stimulus to the dorsal horn of the spinal cord instead of the medulla, because nociception travels along very specific separate C fibers. From there, the stimulus travels up the spinal cord into the thalamus, where it then gets relayed to its somatosensory location in the cortex, where the brain either perceives it in some way or ignores it. But if it can't be ignored, this is when pain is perceived, and where rubbing the area with a hand comes in handy to help close the pain gate. Okay, so here's how specific qualities of touch help gate pain. When a hand, either your own or that of a skilled therapist, puts their hand over the painful area and rubs it, that particular stimulus, kind, light, warm, pleasant hand contact, gets carried along a different set of fibers, A beta fibers, which send a collateral branch into the dorsal horn of the spinal cord, and the rest of its fibers send the pleasant signal to the medulla, as we covered in the touch physiology review. But here in the dorsal horn, the A beta fiber collateral branch stimulates an interneuron, which inhibits or gates the transfer of the nociceptive input from the C fiber. The A fiber cuts nociception off at the pass in the dorsal horn of the spinal cord. And this is another foundational layer to how the DNM approach and all manual therapy works. We call this pain gating bottom-up modulation. Now, At the same time, nociception is being dampened from this bottom-up gate. Another inhibitory pain mechanism, known as descending modulation, is also at work. This mechanism initiates when we engage the brain itself with cognitive approaches like pain neuroscience education. And this modulates pain perception in the other direction, from the brain down to the dorsal horn of the spinal cord. We call this the top-down modulation of pain. It's very cool stuff, but a little too much to get into here, and I know by now you are very eager to get into the techniques. We do a full breakdown of descending modulation and how to use it in practice in the full course. Oh, and one last thing. The ruffini are comprised of the A beta fibers responsible for the bottom-up gating of pain perception, which is another reason we want to specifically engage the ruffini corpuscles. They can serve as very effective pain gates when we understand exactly how to switch them on. And these techniques do exactly that. Now let's put this all together in practice. All right, here we go. So to begin working with the 6 techniques, let's just remember the following points we've learned so far. Nerves move independently from other tissues. We're targeting the more superficial cutaneous nerve branches via the skin and not other tissues directly beneath. And we are aiming to help them move more freely in their neural tunnels. Next, compression, excess tension, and immobility can compromise the circulation of vessels that feed the nerve with oxygen and glucose, or drain it of metabolic waste. We want to help create space and provide the conditions so it can restore its normal neurovascular flow and self-correct. We are primarily working to target the ruffini corpuscles, which are stimulated by slow, sustained holds with skin stretch. And because the ruffini corpuscles are also thermoreceptors, which detect warmth, we should also make sure our hands are warm upon contacting the skin. The contact should also be light enough to avoid triggering any discomfort. Remember, DNM should never, ever hurt. Next, we want to engage the cognitive brain. One easy way to practice this is, instead of performing the techniques on patients at random, briefly ask and invite, hey, would you like to try something out? And if they're okay with it, then let them know this kind of technique is very gentle and slow because it works with the nerves specifically in the skin. It should be gentle so we can target these nerves specifically and help create space around them. And often that can help get better circulation to them, in case that's been the overlooked issue, or something like that. The idea is that the patient has a picture of what's happening under the skin. This almost always makes sense to them. It gets them involved. Then say, if you can, please let me know when or if you feel any changes in sensation, because that's very helpful for me. You're in charge here, and the job of my hands is to follow your lead. And remember, this shouldn't hurt. That's an example. Then you ask them for feedback as to which of the techniques feels best to them, and do that one. Of course, you might offer any 2 or 3 to start. This is just so you can get the hang of it, and they can too. And remember to encourage healthy movements that can offset compression or tension in the nerves after they leave. These don't need to be complicated, and it's actually great when they can be kept simple. Remind them that it's okay to feel a little discomfort and that hurt does not equal harm, especially if there's no acute injury or anything more serious that has been ruled out. Okay, so as we introduce the 6 techniques, these following points apply to all of them. And please understand that in pure DNM, the techniques work best without any lubricant to get the best skin stretch. But of course, always do what's more comfortable for the patient. So each hold is held for a minimum of 90 seconds to 2 minutes for starters, because the Ruffini corpuscles need a sustained skin stretch in order to be stimulated. This is a good baseline, and of course, those times will vary as you get the gist. Remember, less is more. The stretch of the skin should be the minimal amount required for effect. It should feel soothing to the patient and never hurt. Now, the handhold must be careful, consistent, and steady, not to push, squeeze, or vary outside of that position. At first, this might feel challenging, but then it becomes kind of like a meditation. This shouldn't hurt you either. So if your hands get uncomfortable, change position and shake them out, because it's just as important for you to be relaxed. The job of your hands is to follow and adapt to the slow, subtle changes under the patient's skin, but not the other way around. You are not in the role of doing, but rather responding. You are an interactor and not an operator. The idea beneath the different holds is to move skin in a way that is pain-free and offloads the neurovascular structures. When the client indicates which one of the techniques feels the most soothing to them, we take that as a hint that we're moving in the right direction. Okay, so let's take a moment to make sure that your hands are as relaxed as possible. Shake them out for at least 15 seconds. I find this simple exercise helps get rid of any unnecessary tension in my hands. Next, rub them together until they feel warm. This helps with your tactile receptivity, which can help you feel for changes in the tissue better and be better prompted to check in with the patient for feedback. Okay, so here's how this demo is going to work. You'll see this is going to represent the site of soreness, and also that there's quite a range of mobility in the epidermis as soon as you start working with the skin more. Now please note, the techniques in this video are somewhat exaggerated to demonstrate the movement of the skin around the site of soreness. Though these deeper handholds may feel satisfying for some patients without more sensitive pain complaints, for others often a barely imperceptible skin stretch is plenty. Remember, it should never hurt or aggravate, and less is more. Also, these techniques should only be considered suggestions. It's good to experiment with different skin mobilizations and directions until it begins to feel natural. Okay, so our first technique is going to be longitudinal distraction. And remember, this will represent the sore spot. Now, you'll see there's lots of movement in the skin, and this movement can also benefit the larger nerve branches underneath that feed into the cutaneous nerves. For longitudinal distraction, we're going to want to gently traction skin away from the site of soreness and hold steady for 2 minutes. Again, away from the site of soreness, and we're going to hold steady for 2 minutes. And it's also important when you release the hold to do so as slowly as you went into it. So remember, this whole technique is slow. So slow and steady. Okay, now we have unloading. In unloading, we want to gather skin from either side of the site of soreness and bring the skin in towards it as if we're moving to bunch it up slightly. Remember, less is more, and minimal effective application is key. Holding for about 2 minutes and releasing slowly. Okay, next we have shearing distraction, and this is one you might be familiar with as it's commonly seen in myofascial release modalities. But remember, in DNM, the skin is the target tissue. That's all we're aiming to move and work with, as that is what the Ruffini are detecting the stretch in. So think skin and not fascia. It is an entirely different layer of focus. And here we have rotational shearing, or twizzling as Diane likes to call it. This is a gentle twisting of the skin, and it can be applied in many different ways and directions. So experiment with gentleness and see which your patient prefers. And you can also grasp and lift up just a little bit as you twist. Now, these last two are ballooning types of techniques. We'll start with contralateral unloading. Here, we take the skin on the opposite side of the appendage, be it an arm, leg, the neck, and we balloon it in a direction away from the site of soreness. Remember, we are still holding these for about 2 minutes if possible. And finally, we have circumferential unloading. Here we want to draw the skin in and slacken it in towards the sore area. This differs from unloading in that with unloading, the skin moves linearly towards the sore area from opposite ends. And in circumferential unloading, the skin is gathered in towards it circularly from all directions at once. And of course, one last thing to note, moving slowly also means releasing the handholds very slowly and not just letting go. This little detail makes a huge difference. Okay, so there you have it. Now you have the foundational keys to start exploring DNM in practice. We packed a lot into today, which is also the introduction to the actual course, so you already have a head start. I hope some of what you've learned in this video can be of benefit to your patients and to you as well, because that's what it's here for. Now, there's even more hands-on application in the full course where we go into a lot more depth and detail on how to treat specific cutaneous nerves in each area of the body for various pain presentations, and how to use DNM alongside modalities like positional release or strain counterstrain, if you prefer that term. We also work with DISOM and so much more. The course is kept current, and if any research findings are to change in the future, you can be sure the curriculum will be updated and you will have access to those updates. It's been an honor and a pleasure to share DNM with you, and may it be a valuable addition that can expand upon what you already do. For more information, you can always visit dermoneuromodulation.com. But till then, I hope to see you inside the course. Thank you so much for your time, attention, and curiosity, and I hope you really enjoy playing with DNM.